So this is about vascular surgery. The topics are acute limb ischemia, CVS anomalies, graft bypass vascular disorders, lower leg ulcers, amputation, varicose veins, and time is 60 minutes. Let us cover acute limb ischemia. So what about this acute limb ischemia? Summary vascular surgery, acute limb ischemia, ankle. So acute limb ischemia is a surgical emergency. Acute thrombosis in a vessel with pre-existing atherosclerosis is most common. There has to be some atherosclerosis, and thrombosis is most common cause of acute limb ischemia. Other causes are arterial embolus, trauma, aortic dissection, thrombus. Clinical features of acute limb ischemia: the person has got 6 P's: pain, pallor, paresthesia, paralysis, poikilocytoma. Timeline for clinical appearance: first 6 hours initially there is white, then 6 to 12 hours mottled appearance, more than 12 to 24 fixed mottling. So management is 6 hours white leg, sensory motor deficit is there initially, so prompt surgery and embolectomy has to be done using Fogarty balloon or balloon catheter. Then if 6 hours has been passed, dusky red, then you have to go for angiography. More than 12 hours to 24 hours, the amputation is the treatment then. Now, if you see what are the general principles of management, acute limb ischemia surgical emergency should be resolved within 6 hours to prevent complication. General principles to follow are: resuscitate the patient, adequate analgesia, immediate anticoagulation with 5,000 units heparin, restore arterial continuity, role of thrombosis. Intra-arterial thrombosis may perform to allow clot reduction and tissue plasmogen activator. Streptocan is inserted through the catheter in the clot, and under fluoroscopic control, clot dispersal can be monitored serial arteriography. If failed more than 48 hours, process with the embolectomy. Chronic ischemia, recent CVA. Causes of critical limb ischemia: there can be recent CVA, recent surgery within 2 weeks, bleeding thighs. Contraindications: these are thrombolysis should not be given if there is recent CVA, bleeding catheter performed through Fogarty balloon catheter. Surgery of choice is patient presenting within 6 hours. Transverse arterectomy easier to perform. What is ankle brachial index? Commonly performed vascular investigation is ankle brachial pressure index. ABI highest ankle, CBI lower limb pressure divided by highest brachial pressure. So ankle pressure is above and brachial pressure is below. Allows for classification severity. Monophasic. What is that? Assessing the vessel. Monophasic signal is proximal stenosis and reduced flow. Triphasic signal is healthy vessel. False reading. What is triphasic is healthy. Monophasic is proximal stenosis plus flow is reduced. So you keep the Doppler beyond this, and blood pressure cuff is inflated, and just to see the blood pressure. Systolic pressure recorded in the brachial artery, then systolic pressure recorded in the dorsal pedis or posterior tibial artery. That is for the ankle. If you see what are the different levels, 1.2, you can see 1.2 is supposed to be the above. Normal is 1 to 1.2. Figures are 1 to 1.2 is normal, 0.8 to 1 is mild, 0.5 to 0.8 is moderate, and less than 0.3. 0.3 to 0.5 is significant, and less than 0.3 is very critical limb ischemia. So duplex scanning to delete lesions needed compressive bandage. So this is acute limb ischemia. Next topic is what are the CVS anomalies. CVS anomalies. Aortic dissection most common than rupture of 33% die within first hours, 50% die in 48 hours, associated with hypertension. Features of aortic dissection: tear in intimal layer followed by formation propagation of subintimal cystic medial necrosis. Marfan syndrome most common site of dissection, 90% occurring 10 cm. Typical location treatment: ascending aorta, aortic root replacement, descending aorta, medical therapy and antihypertensives. Tearing is a hypertension, blood pressure difference greater than 20 mm of Hg in right and left. Neurological deficit investigation: chest X-ray is wide, and CT angiography of thoracic aorta, MRI angiography conventional. Congenital heart disease is cyanotic, more common ventricular septic defect, VSD. Acyanotic means VSD. If there is blood is going from left to right shunt, so it is acyanotic, left to right, and cyanotic is right to left. The patent ductus artery is co-articulation of aortic wall stenosis. VSDs are common than ASDs. However, in adult, ASDs are more common. New diagnosis: and cyanotic most common is tetralogy of Fallot, transposition of great arteries, tricerebral atresia, Pulmonary wall stenosis. Types of murmur: ejection systolic murmur. Whenever there is aortic stenosis, ejection from the left heart, if it is going to the aorta, so there has to be stenosis in the exit wall, so aortic stenosis. Pulmonary stenosis, right ventricle, when there is pumping, atrial septal defect, phallus tarsology, mitral regurgitation. Pansystolic murmur, when there is systole and you are getting continuously murmur, so ejection systolic is in the initial aortic stenosis. Mitral regurgitation, when there is contraction of the right and left ventricle, if the mitral wall or tricuspid wall is uh, incompetent, then the walls get return and got regurgitation and ventricular septal. That is pansystolic. Late systolic, at the end, when mitral wall is prolapsed, coarctation of aorta. Early diastolic means when the ventricles are relaxing. It means aortic wall need to be closed and the blood is flowing back from the aortic wall. It is early diastolic. It's also called as Gram-Steele murmur. Then mid diastolic, when early diastolic and mid diastolic. If mitral stenosis is there, Austin Flint murmur is also called as. Gram-Steele is early diastolic, mid diastolic, Austin Flint murmur. Four characteristic features of this tetralogy of Fallot. Ventricular septal, right ventricular hypertrophy, then right ventricular outflow obstruction, pulmonary stenosis, and overriding of aorta. So ventricular septal defect is generally in the upper part. The severity of right ventricular outflow obstruction determines the degree of cyanosis, and other features of cyanosis causes right to left shunt. Whenever there is right to left shunt, ejection systolic murmur due to pulmonary stenosis, and right-sided arch aorta is 25%. Chest axis should boot-shaped ECG because right ventricular hypertrophy. Surgically taken, cyanotic episodes may be helped by beta blocker. Next topic is graft, vascular grafts bypass for indications for surgery to revascularize the lower limb. What are the indications? This is intermittent claudication, critical ischemia, ulceration, gangrene. Intermittent claudication that is not disabling may provide relative indication, whilst other complications are often absolute indications depending on the patient. You have to do assessment, clinical examination, ankle breaker intakes, duplex ultrasound, angiography. Angioplasty, in order to angioplasty to be undertaken successfully, the artery has to be accessible, the lesion relatively short and reasonable distal runoff. Long lesions may be amenable. Surgery will be undertaken when attempts at angioplasty have either been failed or unstable. Bypass essentially involves bypassing the affected arterial segment by utilizing graft to run above the disease to below the disease. Some key concepts with the bypass surgery is superficial femoral artery occlusion to above knee popliteal. In the ideal scenario, either in situ or reverse long sequence vein should be used as a conduit. However, prosthetic material has reasonable 5-year patency rate. Some would advocate using this preference to so that vein can be used for further other procedures in future. Procedure is after dissected out IV heparin is given a long longitudinal arterectomy graft cut to the size and tunnel to the arterial sides. Anastomosis to femoral artery, usually 5-0 proline suture is used. Distal anastomosis using 6-0 procedure. Femoral distal bypass surgery takes longer to perform, more technically challenging and higher. In elderly patients with poor runoff of primary, amputation may be safer than vein mapping. First, see whether there is suitable vein. Peripheral conduct. Subintimal hyperplasia occurs with polytotal fluoroethylene often distal anastomosis. Early operative procedures above knee femoral popliteal. If insufficient vein for the entire conduit, then vein can be attached to the end of polytotal graft. Remember, the more distal the arterial anastomosis, lower the success rate. Now, what are the lower leg ulcers? Most due to venous hypertension secondary to chronic venous insufficiency. Other causes include calf pump dysfunction. Ulcers form due to capillary fibrin cutoff or leukocyte sequestration. Features of venous insufficiency include edema, brown pigmentation, lipodermosclerosis, eczema. Location above the ankle painless. These are lower leg ulcers. Deep venous insufficiency is related to deep vein thrombosis. Superficial venous insufficiency associated with the varicose veins. Then Doppler ultrasound looks for the presence of reflux, and duplex ultrasound looks at the anatomical flow. Duplex is the anatomical and Doppler looks for the reflux. Management is 4-layer compression banding after exclusion of the arterial disease. If it fails and heal after 12 weeks, More than the skin grafting may be needed. Venous ulcers, uh, marginal squamous cell carcinoma. What are the complications that may occur in the venous ulcers? Squamous cell can occur in the site of chronic inflammation. May occur marginally is the malignancy. Arterial ulcers occur at the toes and heel, painful. There may be areas of gangrene. Arterial ulcers. This is arterial ulcer. Neuroprotic ulcers at the bottom, commonly over the plantar surface due to pressure. Pyoderma gangrenosum associated with inflammatory bowel disease, erythema. Pyoderma gangrenosum. Amputations are indicated when affected limb is one of the following non-dead, deadly, useless. Amputation often taken as often last resort limb salvage failed. Chronic failure and vascular. First two categories are most prevalent diabetic foot sepsis and general in these types of amputation. Vast majority of the main categories of amputations are pelvic disarticulation, Avoni amputation, gritty stroke through knee, Sims amputation through the ankle, amputation of the midfoot, choosing the level of amputation, desired functional outcome, comorbidities, Avoni amputation quickly performed. So here is the deep articulation. So levels of amputation you can see here. Hip disarticulation, above knee amputation, disarticulation, the below knee amputations. Now below knee amputation technique is more challenging. Heal reliably than their above knee counterparts, less reliably. However, many more patients are able to walk using below knee prosthesis. So marking the flaps of Burgess flap, longitudinal flap, you have to take 10 to 12 centimeter from tubal tuberosity. Then you cut the deep bone. Then you get lower flap, that is called as Burgess flap. Now you could Sims amputation is in this manner. This is Chopard amputation, Lisfranic amputation to metatarsal, transmetatarsal amputation to amputation, showing the line cut in the femur. So this is gritty stroke. Patella is used and the femur is cut like this. This is like this. Patella is not removed in gritty strokes. Now if you see, this is the varicose veins. Varicose veins dilated, tortuous and elongated veins allowing for reversal of the blood flow due to valvular reversal. Veins, elongated veins, venous system of the lower limb. If you see, femoral vein is like this. Great saphenous vein is starting from the medial malleolus, going up and opening femoral vein. And this is popliteal vein or small saphenous vein. It is opening to popliteal vein. Venous system, superficial veins, great saphenous posteromedially and super small saphenous laterally. Deep veins, soleus, gastrocnemius, soleus and gastrocnemial venous sinuses, peripheral heart. Perforators allow unidirection from this. So deep to superficial. Superficial to deep is the normal. Ankle perforators. So how are the perforators? These are the perforators at the ankle. If you see, cockets perforated of the posterior arch, boyds perforated around the knee, dots perforated at the thigh, Hunterian perforators here of May or Custer, ankle perforators, lower leg perforators of cocket, gastrocnemic perforators of boyd, mid thigh perforators. So normally the walls, the blood is flowing from superficial to the deep. So whenever you compress this, they should not fill back from the below. Keep CEAP, clinical, etiology, anatomic, pathophysiology. C is clinical. What you see, C0, no visible palpable signs of venous disease. One is telangiectasia, smaller bluish discoloration and small petechiae like telangiectasia or reticular veins. C2 is varicose veins visible. C2 is again recurrent varicose once you have operated, or C3 is edema. C4 is changes skin and subcutaneous tissue secondary to chronic venous disease. There can be pigmentation, there can be lipodermosclerosis, there can be corona phylebacteria. C5 is healed. C6 active venous ulcer. C6R is recurrent. So this is clinical manifestation. What is the etiology? It is, we have to find out. Cephalofemoral incompetence what? Then etiology means any of the anatomical distribution, pathophysiology. Clinical features. What are the signs symptoms? Dilated, tortuous ankle, flare is there, ankle swelling, spider veins more than one, pain worsens on standing, itching, edema, saphenous varix, discoloration, ulceration, champagne bottle. So signs of varicose vein, this you can see, champagne bottle, and saphenous varix is an inguinal femoral Saphenous varix. This is champagne. Saphenous dilatation of grade 7 at the junction with femoral vein in the groin due to valvular incompetence. Soft compressible expansile cuff fluid thrill is present. Special test of for varicose vein. What is Stendenberg test? Assess the site of superficial venous. This is superficial venous and Perthes test to assess deep venous system. And Schwartz test, standing position, tap the lower part of the vein, felt pulse at saphenofemoral junction. Means when you tap at the lower. Pratt's test, perforators seen blowout. Morris cuff test, simple figures. So how standard test is performed? Elevate the limbs. First ask the person to lie down, elevate the limbs, empty the veins, tourniquet applied just below the saphenofemoral junction. Patient stands up quickly, tourniquet is released, rapid filling from over his saphenofemoral. Test 2 is patient keep the tourniquet while standing for 30 to 60 seconds, rapid filling from below, perforated incompetence. What is venous stasis ulcer? It is a Gator's area around the medial malleolus. Venous stasis ulcer. Most common site is medial malleolus. Shape is shallow flat, edges sloping, margins thin bluish, pale granulation tissue, discharge seroprevalent. Investigation is venous Doppler to confirm diagnosis of varicose veins. Nice guidelines. Then duplex scan to rule out DVT. Condition systematic condition therapy. So what is done? A symptomatic uncomplicated varicose veins. Endothelial. What are the? You can see this. Treatment, management. Symptomatic uncomplicated. What are nice guidelines? Endothermal ablation if unsuitable. Foam sclerotherapy if unsuitable. Saphenofemoral procedure. Ligation. Venous stripping. Varicose vein with skin changes as above. Compression stocking. Class 1. Chronic vein insufficiency 2 to 3 compression stocking. Local wound care and debridement. So what are the vascular investigations? Venous disease and venous Doppler. Simplest investigation to assessment of venous junction incompetence is Doppler. This involves patient standing and manual compression of the limb distal to the junction of interest. Flow should normally occur in one direction. Where junctional incompetence is present, reverse flow will occur and it is relatively easy to identify venogram and duplex scan. Structural venous information is historically obtained using venogram. This is invasive test and relatively modern, rarely required. The most helpful test is venous duplex scan. Doppler versus duplex scan, which will provide information relating to flow and vessel. Duplex is useful in providing vein maps by the bypass surgery. What is there? What you do in Doppler? A medical non-invasive study of heart and blood vessels using ultrasound, which has higher frequency waves. Output is a color picture detecting the blood flow. Information presence of blood in the studied vessel, its direction, speed and turbulence. While duplex, what this is giving? Non-invasive, it is also non-invasive study. Combining traditional ultrasonography and Doppler sonography. A color picture detecting blood flow and two-dimensional grayscale ultrasound image of the tissues. Presence of blood flow in the studied vessel, its direction, speed, turbulence image. So duplex and Doppler. Doppler is what is there? It is a combination of duplex, color Doppler. Arterial disease, ankle brachial index, ankle brachial pressure measurements, ABI again, moderate, less than 3 is severe ischemia, conventional angiogram, CT angiography versus magnetic resonance angiography. CT angiography highly special, progressive, decreased time for examination, availability with low cost. Pros, cons is irradiation exposure, nephrotoxicity. High contrast resolution, ultrasound less available, low time.